The action at the mu receptor is the one that we're most concerned about when we start thinking about combining opioids with benzodiazepines. I've highlighted some of the specific effects that occur when opioids bind to the mu receptor, including sedation, respiratory depression, euphoria, and physical dependence. Those are the things that really make us especially concerned when we think about combining an opioid and a benzodiazepine. The benzodiazepines then have their action at the GABA receptor. The GABA receptor has 5 different subunits depicted here: alpha, beta, and gamma. And you can see the binding sites indicated for the different things that utilize the GABA receptor, including GABA itself, which lands at a different spot from medications like benzodiazepines, zolpidem, which is a non-benzodiazepine hypnotic medication, and then the benzodiazepine antagonist, flumazenil, binds at a very similar site to the benzodiazepines themselves. When a benzodiazepine lands on its landing site at the alpha subunit of the GABA receptor, that triggers chloride channel opening, and that results in the membrane being hyperpolarized, which is the same as saying that the cell is inhibited. It's not able to move into an active state. So when I teach patients about benzodiazepines, I use the analogy of the brake pedal and compare it with the gas pedal. So the benzodiazepines are pretty much always the brake pedal in the brain. And that becomes concerning when we think about things like control of breathing and control of coordination and control of cognitive functions, because benzodiazepines have the ability to dampen those, step on the brakes, and opioids do as well. The benzodiazepines all act in the exact same way. Their mechanism of action is exactly the same no matter which drug we're talking about. And they have many similar clinical applications and side effects. So you can see in the columns, those are combined for all of the benzodiazepines. The main differences between them result from their pharmacokinetics. So the things that are important to highlight about their pharmacokinetics are the half-life of the parent compound, the formation of an active metabolite, whether an active metabolite is formed or not, the half-life of that metabolite, and then the lipophilicity of the drug itself, which is not depicted in this table. But just to kind of highlight an example or two, if we look at diazepam, it forms a highly active metabolite, and the half-life of the parent compound is somewhere up to 48 hours, but the half-life of the metabolite is 100 to 194 hours. So this means that many days after a patient has taken a single dose of diazepam, but especially repeated doses of diazepam, that drug is still hanging around in their system for weeks, even after they've taken the last dose. So if we think about combining a benzodiazepine like diazepam with an opioid that also might contribute to some respiratory depression, some stepping on the brakes effect in that patient's brain, we have to think about, could there still be effects happening because of or could there be effects that happen because of the combination of those two medications being around at the same time, even though, like I said, the diazepam hasn't been taken for a long period of time. If we contrast that with alprazolam at the top of the screen, its metabolite is minimally active, and the half-life of the parent compound is just 10 to 12 hours. So the ability of alprazolam to contribute to prolonged effects with respiratory depression, or even maybe unpredictable effects with respiratory depression when combined with an opioid, is probably less, just because we have such a better ability to determine and predict when the alprazolam has left the central nervous system as compared with diazepam. This slide depicts several different sedative hypnotics, the benzodiazepines on the left. Some sources will break the benzodiazepines down into short action, intermediate action, and long action. Depending on the source that you look at, though, you can see them categorized somewhat differently in different places. This slide is here because all of the sedative hypnotics are of some concern when we think about combining them with opioids. But we focus most on the benzodiazepines because they're used so frequently, so much more than, like, for instance, the barbiturates, which are pictured in the middle. The barbiturates are actually more dangerous when combined with opioids than the benzodiazepines are, but they just have fallen out of favor because of their significant abuse potential, as well as their potential to contribute to the concerns we're going to talk about with the benzodiazepines. The miscellaneous agents pictured on the right are significantly less potent in their ability to induce respiratory depression. So it's not that we should consider them completely safe without any potential risk when they're combined with opioids, but the risk is quite a bit smaller than when we think about using benzodiazepines, and certainly much smaller than when we think about using the barbiturates. This slide depicts some of the side effects that we may be able to see when barbiturates or benzodiazepines are used. So the left side of the slide, the y-axis, depicts the central nervous system effect, and the x-axis, the increasing sedative hypnotic dose. So we can see that as the dose rises, so do the central nervous system side effects. This slide makes it look like the benzodiazepines probably could never cause medullary depression or coma. However, and that is often the case when the benzodiazepines are used on their own, and especially at therapeutic doses. But when overdose is taken of a benzodiazepine, or when benzodiazepines are combined with alcohol or an opioid, it's essentially like we would start our graph up one line on the y-axis. So the benzodiazepine line would start, the blue line of the benzodiazepines would start up one notch from where it's depicted in this slide, meaning that at smaller doses, we could rise to things like hypnosis and anesthesia, and certainly reach medullary depression, which is what we're concerned about things like respiratory arrest, hypotension, cardiovascular collapse, death from overdose. Those are the things that we worry about, because that shifts this curve so that those things can happen at smaller doses of benzodiazepine than they would otherwise in the absence of an opioid or alcohol. Some trends about the use of the combination of an opioid and a benzodiazepine. 2 in 5 persons seeking detoxification for an opioid use disorder used a benzodiazepine in the prior month. So we're talking about a significant chunk of those who are dependent on an opioid have also been utilizing benzodiazepines recently. Amongst 13,146 visits with a new opioid prescription, rates of initial opioid prescribing to persons using benzodiazepines significantly increased in that length of time from 2005 to 2010. And I think the numbers are quite interesting. They're higher than I would have expected. Rose from 189 per 1,000 person visits up to 351 per 1,000 person visits, but then have decreased in the last 8 years, it seems, or at least in that 5-year range from 2010 to 2015, down from 351 per 1,000 person visits to 179 per 1,000 person visits. So you can see, actually, from 2010 to 2015, the rate of comorbid or concomitant prescription of a new opioid with a benzodiazepine actually dropped below the baseline levels that were measured in 2005. So I think that's a good sign that we're paying more attention to the potential harms of this combination. However, higher rates of initial opioid prescriptions were seen among patients concurrently taking benzodiazepines compared with the general population. So we're not without risk, and we're not completely avoiding the problem potentially, but we are making steps in the right direction probably. Just to note, we're going to mention the possibility of making naloxone available for anyone who's prescribed an opioid and a benzodiazepine. And in this study, naloxone was co-prescribed in less than 1% of the visits when a patient was concurrently prescribed a benzodiazepine and an opioid. So a definite area of improvement was noted by the authors of this study. So what are the risks of concurrent use? And what do the data say about these risks? Alcohol and benzodiazepine use disorders are considered a contraindication to medication-assisted therapy because they increase the risk of mortality and relapse. However, the FDA put forth a sort of additional statement about that. They advise that buprenorphine and methadone should not be withheld from patients taking benzodiazepines or other CNS depressants. So we have direction not to use this combination intentionally or as maybe a long-term strategy in as many or in as few patients as we possibly can, I guess you would say. But it's also important to note that in someone who is needing medication-assisted therapy and it's indicated because of their problematic opioid use disorder, that we should not withhold that just because they are also dependent on a benzodiazepine. Among veterans receiving opioids, concomitant benzodiazepine use is associated with an increased risk of adverse outcomes when compared to the baseline risk of opioid-only using veterans. And those adverse outcomes were defined as opioid-related accidents and overdoses, alcohol and non-opioid drug-related accidents and overdoses, self-inflicted injuries, violence-related injuries, and wounds or injuries overall, as well as all-cause death. So that's a big conglomerate of adverse outcomes, but I think the main take-home message is probably there's a good chance that we may be increasing risk for harm when we're using the concomitant combination of a benzodiazepine and an opioid, compared with if we can work to use just an opioid and not the benzodiazepine on board in addition. Among veterans prescribed an opioid, risk of death from drug overdose increased with a history of benzodiazepine prescription with a hazard ratio of 2.33 and a current benzodiazepine prescription with a hazard ratio of 3.86. So risk of death from drug overdose increased as the daily benzodiazepine dose increased, which probably isn't that surprising given the graph I showed you a few slides back. And compared with clonazepam, temazepam was associated with a decreased risk of death from drug overdose. That also might not be surprising if we were to flip back to our slide showing the half-lives of clonazepam and temazepam. The half-life of clonazepam is a fair amount longer than is that of temazepam. And so that stays around much longer and has the potential to contribute to respiratory depression for a longer period of time once an opioid is added. Concomitant use of benzodiazepines is the most common factor in prescription opioid-related overdose deaths. So I have pondered the question often, and maybe several of you have also, is buprenorphine in combination with a benzodiazepine safer than some other opioid in combination with a benzodiazepine? And I think clinically, the answer to that question would be very useful for many of us because we would like to think that we're making our patients safer in several ways by using buprenorphine instead of maybe whatever other opioid they were dependent on. But specifically as it relates to benzodiazepines, I don't know if we can rest assured that we are making our patients safer that way. Joint consumption of buprenorphine plus diazepam or clorazepate, but not bromazepam, so 3 different benzodiazepines administered in combination with buprenorphine, was shown to increase the reward properties of buprenorphine in mice. It hasn't been repeated in humans yet, so we don't know for sure if that effect could be seen, but there's the possibility that adding that benzodiazepine in addition to the buprenorphine may actually make it more pleasurable and perhaps potentially more likely to bring about dependence or aberrant behaviors. Amongst toxicology cases involving non-medical use of methadone or buprenorphine in combination with a benzodiazepine, there was a higher hospitalization rate and greater risk for intubation in those people who were taking methadone compared with those who were taking buprenorphine. So this is just the cases that presented with toxicology or overdose of either methadone plus a benzodiazepine or buprenorphine plus a benzodiazepine. But the buprenorphine appeared to confer a little bit lower risk for adverse outcomes in that overdose situation, at least in the way of lower hospitalization rates and lower risk for needing intubation. Benzodiazepines have been reported to negate the plateau properties of buprenorphine, maybe concealing the purported safety advantages of buprenorphine versus other opioids. This was in I believe, a subjective effect study in humans, and kind of in some ways supports the first bullet point on this slide that perhaps the addition of the benzodiazepine negates some of the safety profile of buprenorphine as compared with other opioids. However, we have not compared benzodiazepine plus buprenorphine against any other benzodiazepine plus, or excuse me, against benzodiazepine plus any other opioid in any sort of head-to-head study. So it's hard to draw a conclusion about whether benzodiazepines increase the pleasurable effect of opioids, period, or if they do it just with buprenorphine, or if we would see the effect be even larger if we were talking about a benzodiazepine plus morphine, for example, as compared with benzodiazepine plus buprenorphine. Don't know the answer to that question yet. And finally, amongst patients in an opioid maintenance treatment program being prescribed buprenorphine naloxone, urine positivity for benzodiazepines was associated with higher dropout of treatment compared with other substances or any other patient characteristics. So that factor in and of itself, that urine positivity for benzodiazepines, confer greater risk for non-completion of treatment. Diazepam 40 milligrams increased the intensity of subjective drug effects for both methadone and buprenorphine, independent of the opioid dose, amongst opioid-dependent patients. So again, we see this potential for the lack of euphoria conferred by buprenorphine actually being reversed by the addition of a benzodiazepine. Amongst high-dose opioid-dependent patients, a dose of 40 milligrams of diazepam produced some evidence of respiratory depression in those who were taking methadone, but not in those who were taking buprenorphine. So this points to the maybe previous assumption that buprenorphine, in terms of adverse effects that could lead to fatality, may be safer when it's combined with a benzodiazepine than when methadone is combined with a benzodiazepine. One small study that supported that hypothesis. A 2 milligram dose of alprazolam was associated with greater impairment on performance measures in methadone patients, but not in buprenorphine naloxone patients. So again, a repeat of a supported finding supporting the bullet point above, that again, safety outcomes in terms of the central nervous system side effects when combining a benzodiazepine with buprenorphine seems like it may lead to a little bit better outcomes than when benzodiazepine combined with morphine. Did I say that right? Benzodiazepine plus buprenorphine seems like it might be a little bit safer on some of these central nervous system related outcomes. And finally, survey findings suggest greater subjective and respiratory effects following benzodiazepine use in patients while receiving methadone rather than when they're receiving buprenorphine. So the overall takeaway about benzodiazepines plus buprenorphine, it's still challenging to draw a definite conclusion. There hasn't been a head-to-head comparison about combining buprenorphine in a benzo or another opioid in a benzo, so we can't draw firm conclusions. But it appears that adding these small studies together, there is some trend for greater safety when benzodiazepine is combined with buprenorphine as compared with when it is combined with some other opioid. But it's not without risk. There does seem to be lower risk or lower treatment completion, increased sedation, a greater risk of respiratory depression when a benzodiazepine is on board with buprenorphine compared with when buprenorphine is used by itself. So some thoughts about how we might manage benzodiazepine patients, or excuse me, benzodiazepine dependence in patients who are on MAT. And this is taken right from the references listed there from the American Journal of Addiction. They suggest that we should always be coordinating treatment providers so that whoever is prescribing the benzodiazepine, if it's not the MAT provider, that they're fully aware and communicating with one another, addressing co-occurring medical and psychiatric disorders, stabilizing on a long-acting benzodiazepine, which I think is interesting because that kind of goes against what we saw with the long half-life benzodiazepines, increasing the risk for respiratory depression. However, I think the rationale for that statement is that the long-acting benzodiazepines perhaps have a little bit lower risk for themselves being misused and abused and conferring euphoric effects. And so a long-acting benzodiazepine seems like it is likely to provide a little bit more stable anxiety control and also prevent kind of that yo-yo effect that promotes greater reward when the dose of the benzodiazepine is taken. It's recommended to attempt gradual dosage reductions of benzodiazepines, trying to target the lowest effective dose that is possible. Limit access to benzodiazepine medications from other sources if possible. Identify and address aberrant drug behaviors in the treatment plan. Undertake regular monitoring, including clinical review, urine testing, and prescription monitoring systems. Utilize contingency management principles regarding treatment conditions. Develop a written treatment agreement, and document those treatment decisions. So probably things that you would think of if you hadn't read this slide, but I think it helps to just reinforce that probably several different factors, several different approaches would be recommended to make sure that the risk is the lowest possible when someone is concomitantly taking a benzodiazepine and receiving medication-assisted therapy, especially or even with buprenorphine. So some additional strategies that I might also add. I think I would strongly recommend that naloxone be available in the home and amongst the loved ones of any person who is receiving a benzodiazepine as well as an opioid. The data are very clear that risk for overdose death is much higher in people who are taking both medications compared with one alone. Another possible strategy would be to provide smaller medication supplies. This is something we've talked about periodically in this group before. A recent study indicated that physicians were willing to provide fewer days of buprenorphine supply when patients had a benzodiazepine use disorder or when they reported to be taking a benzodiazepine, compared with if they had no benzodiazepine use. So smaller supplies of buprenorphine and potentially smaller supplies of benzodiazepine as well. If a benzodiazepine taper seems feasible, then we might consider other medications to help manage anxiety or insomnia. I've listed several different options there, several of which have been shown to be equally effective for some of the indications that benzodiazepines are used for. For example, gabapentin and pregabalin in different anxiety disorders have been shown to be just as effective as a benzodiazepine in the short term as well as in the long term, perhaps even more effective in the long term. So if there's a possibility of tapering off the benzodiazepine and controlling the anxiety in other ways, that would certainly be encouraged. Potentially instituting an opioid taper, if we're not talking about a patient on a MAT program, but they're using another opioid to manage pain, might there be the possibility of controlling pain with other strategies? A recent study has shown that that the opioids were no more effective than non-opioid therapy for chronic back, hip, and knee pain. And so maybe we can make sure we discuss that information with the patient in detail and see about controlling pain with things like duloxetine, pregabalin, tricyclic antidepressants. And then, of course, transition to MAT if the treatment of their pain with a non-opioid is not possible, or also if we just need to work to that outcome to keep them in our treatment program or whatever. If we're going to use MAT, perhaps buprenorphine would be preferred if a benzodiazepine needs to stay on board. And that's all I have to say. I would be glad to take any questions if anybody has any.
Well, Dr. Werremeyer, this is Dr. Schmitz. Thank you much for that presentation. I think there's quite a bit to chew on there and a lot of good detail. There are just a couple of questions in the chat box already. Remember, you can submit those there. I'll handle those first two from the chat box, and then otherwise people can certainly unmute their mics as well as we get into discussion. Please do that. The first, I think, really has to do, to a certain extent, with pharmacodynamics. And the question is, how does the parent or metabolite hours change when benzodiazepines are taken by other routes other than orally?
It does not change. So the potential or the amount of time it takes for the medication to get into the bloodstream may change depending on the route of administration. But once the medication is in the body, it is treated the same by the body no matter how it got there. So the half-life does not change for the medication itself nor for the metabolite.
Thanks. And I don't know if that fully answered the person's question, but please feel free to bring that up again for further discussion if it does not, or if you'd like to discuss another nuance of that. But the other has to do more so with, I think, the issue around buprenorphine plus benzodiazepines, and are those safer than the administration with benzodiazepines and other opioids? I don't know if Dr. Patel or someone else, would you have specific either experience or be able to comment on the nuance of that? I know we discussed there's maybe some lacking with regard to significant evidence, but there may be experience in the field or standard of care.
For us, basically what we're seeing, and this is, I can't get my screen to work. Anyway, so what we've been seeing is that our patients are not getting turned away if they're on currently on some kind of benzo, whether they're prescribed or getting it off of the street. To the point of the lecture, though, we're trying to minimize the polypharmacy and taking control of those medications. what we want to do as best as possible is move patients off of Xanax. We are trying to use Klonopin for a couple reasons. One, it's the medium acting, intermediate acting, I think is the way that it's described in this. We have a little bit better ability to space those out, getting away from the patient's need for the immediate satisfaction that they typically get with the Xanax, prazolam. In those patients that are mixing the medications, we want to work as best as we can to help explain to them the respiratory depression aspect of it. And it is what it is. Some of the patients get it, some of them don't. What we can best do is educate the patient, not only the patient, but the prescribing medical provider, often which times is a little bit more difficult than getting through to the patient.
Thanks for that comment. Are there other questions for our presenter? Are there items for discussion related to the didactic?
I just did want to make a comment that the FDA did address this, and this was one of the points that was shown in the slide. The FDA did put out some guidance on buprenorphine, MAT and benzo concomitant use, and I think a key take-home is that yes, we should be very observant in dealing with this combination, but at the same time make sure that the level of comfort is there to not turn these patients away. These patients need to be taken care of as well.
Great, thank you. Any other discussion items before we thank Dr. Werremeyer for her presentation today? I think it's an important concept, and we certainly don't want to have this area be ambiguous enough that it stops us from being able to administer proper treatment to our patients. So I'm really glad that we're discussing this. I think it's an important issue.
I have a quick comment about it. I found that a lot of clients that we have at, taking methadone that have come from other clinics where they've been on buprenorphine, they're on high amounts of or more benzodiazepines because the buprenorphine just isn't covering their overall addiction. So in this area, if clients are able to, then I often would try to transfer them to methadone and on daily dosing, especially on the benzodiazepine. That way they're a little safer and you can lay eyes on them every day versus leaving them on buprenorphine, just as a suggestion.
Thank you. Other comments or questions? Amy, thank you for the presentation. I'm going to go ahead and move us into the case presentation. Before I do, I'll just again remind everyone that we do want to make sure that we are protecting patient privacy. So if any of you see an opportunity to just break into the conversation and by necessity protect patient privacy, please do so. But otherwise, we'll be sharing a case that is brought to us actually by our team, Chris Harsell, who is Chief Medical Officer and a nurse practitioner at Valley Community Health. Appreciate your taking the lead on this, along with Kristen Young, who is MAT Nurse and Care Coordinator at Valley Community Health, and Robin Landwehr, who is, again, an Integrated Care Manager for Valley Community Health Centers here in Grand Forks. So that's our team for the presentation today, and I'm really happy that you'll be able to bring this to us, and then we'll be able to share that with our other spokes to be able to see how in a context we may be experiencing some of the same issues and learn together. I'll turn it over to you. And Chris, are you there? And I think we've unmuted you there at Valley Community Health. Chris, are you able to hear us? Hello.
Hello, we're here.
All right. Well, Chris, I just introduced Chris, Kristen, and Robin to be able to share our case. Thank you.
Can you hear us now?
We can.
Okay, great. Sorry, our camera died and we didn't know what happened. Okay, this is Chris. We're presenting a case of we had a 52-year-old female patient who recently relocated to North Dakota in January. She is currently residing at the homeless shelter at the time she came to see us. She has a history of chronic pain related to trauma, specifically domestic violence. Also a history of asthma, previously treated Hep C. She's a smoker and has a history of both alcohol use disorder as well as opioid use disorder. She's been in and out of treatment for the last 3 years, previously taking Bonneville twice daily, but had been off that since August of 2017. And we were able to confirm that with her old records and on the PDMP check in her previous state. Since leaving, she's been seen at various offices, sort of drug seeking for the chronic pain, and she's been prescribed oxycodone. She also told us that she's been buying some opioids on the street just to sort of keep her cravings down, and the PDMP confirms that as well. Her current prescribed medications were an albuterol inhaler, a budesonide inhaler, some Flexeril, some gabapentin, and Mobic, which were prescribed by a pain management specialist who was trying to obviously not use narcotics on her. She was actually seen initially at our clinic during a women's health screening event, so she was here for PAP, and the midwife who saw her did a really great intake. And so during that history, she admitted that she continues with cravings and withdrawal symptoms that include nausea, chills, stomachache, diarrhea, and a deep body pain. She's basically been managing those symptoms with buying street drugs or upping her gabapentin as needed, and she's even tried herself on Suboxone in the past, which she thought was working well. She did tell us that although she's not using regularly, I would use drugs if they were available, but I'm just trying not to. So when she heard that we were offering MAT, she asked if she could get back on it. She knows she does better on buprenorphine. She told us, I feel happier and I do better. And so we were able to have Kristen do her, our care coordinator, do her intake, get her old records. We confirmed an opioid use disorder, her previous bupe prescriptions, and sort of assessed if we thought she'd be stable for office-based MAT. It appeared from her old records, interestingly, that she was pretty good in terms of her visits and her compliance with the MAT program, except that her very last urine drug screen before she left town screened very high for buprenorphine with no metabolites, which indicated to us that perhaps she had sprinkled a pill into her urine rather than having it in her body. And she reports she was discharged from her previous MAT for meth use. So our primary concern or goal for this case was that, is this an appropriate patient to restart, in particular office-based MIT? And is restarting someone who's not necessarily actively using daily the same as an induction or appropriate? Some contributing factors that may have kept the patient from progressing to a desired level, well, her polysubstance abuse. She is worsening off the MAT. She has a history of trauma, which we see a lot. She's currently experiencing homelessness. She currently relocated, which is a big stress, and she doesn't have many social supports in town. So those were all things we took into consideration. Common triggers or stressors, we just had a concern about, like I said, her chance of success if we restart medication-assisted treatment for her. So strategies, we have our MAT team meets every week, and so we sort of talked about whether or not what we thought we should do. We conferred with Dr. McLean as well. She was previously successful on MAT. She's not doing well since going off it. She's provider shopping. She's exhibiting risky behaviors. She has cravings and worsening moods. And she's expressing a willingness that she wants to try it. So we opted to move forward. And we did all our blood screens. Her urine drug screen was negative for all controlled substances, and that was confirmed. She was not pregnant. Her metabolic panel and CBC were within normal limits. STD, HIV screen were negative. She did screen positive for Hep C again, so she was either reinfected or didn't complete treatment. So that was the only thing that was concerning that we'll keep watching with her.
Well, great. Well, thank you for presenting this case. And I'm just wondering if anyone has any clarifying questions. And then, the first question really was, is this appropriate to restart MAT with a patient such as the one we've been discussing? So that would be the first question, as well as anything clarifying. Comments from the group? It sounds as if you did decide to, and it sounds like, as I'm hearing you weigh that, that she was previously successful on MAT, that she had not been doing it as well after not being on MAT. And so are those some of the factors? I know, Dr. McLean, you weighed in, it sounds like, but are those some of the factors that you look at with regard to the risk-benefit? Because the other concern was that if we restart MAT, that maybe it won't work out, because it didn't work out the last time. So concerned about the chance of success, but I'm sure weighing the risks and benefits of either starting MAT or not. That must have been the consideration.
That was, and I think I can ask Robin to weigh in. We use a tool from, and I can't remember the name of it, from something we received in Vermont that sort of gives a patient a score in terms of whether or not their level of likelihood of success in office-based treatment. So we sort of went through that. It identifies all the things we just talked about: previous success, social supports, employment, housing, those kinds of things. So she was walking on the border on a lot of those things with the homelessness and the no job. However, she was working on housing. She was wanted to start with voc rehab, and we just erred on the side of that this would give her this might help her be able to move forward if she's not worrying so much about finding drugs and can focus on other things. So yes, we did. We sort of weighed all that back and forth and decided that we could start her just, of course, on, we saw her, I think, after 3 days after induction, and then she's been on weekly visits for a little bit.
So it sounded like that was your...
Can I ask, this is Lisa Fast. I just want to ask a clarifying question, maybe of the group's opinion. I think this is a really good example of kind of one of those on the fence cases where many providers might struggle with what is disease versus what is volition or decision making, and whether or not this patient had quote unquote decided to fail and wouldn't be a good candidate. I think it's a common presentation, and for primary care, it's often a difficult decision. I just wondered if anyone in the group, based on what they've heard so far, would have decided differently, would have decided that this person was not a good risk because of her previous choices and decision making.
And this is Dave Schmitz. I'll just start by saying, so for example, is there anyone in a small town that doesn't have a homeless shelter? This woman was staying at a homeless shelter, which provides her some degree of a housing transition to get into housing, which is a risk factor, but hopefully allows her to stay in the community to continue her follow-up visits. I think you're right, Lisa. I think as you contextualize this, people think about this in their own communities, some of which communities are smaller than Grand Forks. Would anybody have additional concerns or say, no, this is the right thing to do?
And I think also really the thing that caught my ear was the relapse. You know, this is a person who, in spite of treatment with MAT, relapsed. And I wondered if people would be reluctant to restart it in that instance. Except
she relapsed on meth. So that's not, I mean, I think, yeah, for us, we've been trying to stay very clear that MAT is for opioid use disorder. It doesn't, I mean, while we try to hope and work through all the substance use, that the use, that's not what buprenorphine helps them
right.
stop.
It's not going to protect her from, right.
Right, right. So I don't know that I would define that as a relapse necessarily in terms of her success with MAT.
And I think I agree with you. I don't know if everyone would see it the same way, was I guess the
But
question.
no, you're right. They wouldn't. We know.
But when it comes to me, we talk about the homeless shelter, what I would probably expect in a rural town is that the person may be living in a high-risk situation, couch surfing or staying with other people who may also be using. And at that point, a provider would certainly be probably more cautious about sending a patient home with a prescription of this medication. So I would imagine that what would have to happen is a lot of safety discussion about having the medication. I mean, some providers may even elect to have them come in more frequently if they felt that the patient was living in an unsafe environment.
Yeah, that's kind of what I was getting at. This is David. I when I look at the second question of the three that was brought up, is she an appropriate candidate for office-based treatment, and in what town, in what setting? So here, obviously, in Grand Forks, it was decided she would be a good candidate for office-based treatment in this center, but that may differ. Any comments on what would you do, I suppose, if this patient presented into your office or your emergency room, some of the other we have in the state?
Really quick, one of the at our homeless shelter here, if I'm not mistaken, they don't allow people to have prescriptions like this, but you can turn them in and then they can give them back to you daily. So or it may not be our homeless shelter, it may be one of the other resources that people have for homelessness. But another thing to think about is more people are successful in getting jobs and finding homes once they're established on MAT. So did the egg come before the chicken, or vice versa? So
Good point.
That's been our experience with this patient. She is out of the homeless shelter and in her own apartment and has a part-time job.
This is Dr. McLean. Can people hear me okay?
Yes.
I had the other microphone switched over from this morning. I think what we're talking about is relative risk, and it depends on what resources you have. And I think the other question that Lisa was alluding to is also, what does a previous failure mean? And if we look at addiction, we can anticipate obviously that there are going to be relapses, et cetera. And then the team is debating whether or not it's safe to go ahead and proceed with the plan and protocol that they have in place, versus saying, no, you have to go to a higher level of care and we're not going to treat until that happens, et cetera. So I think an important thing is recognizing, what the risks and benefits are and documenting as such. But I know that Valley is also looking at the potential for having an LAC on board, which may also help the situation as well.
Thanks for that, Dr. McLean. I think that was the question being brought up exactly, is the risk value proposition with regard to the provider being comfortable and the patient having reasonable access to success, and how to set those resources to maximize that opportunity for success. The other question that I heard in the case presentation was with regard to restarting MAT, and whether or not that induction process would be the same if someone was using daily or actively versus not. And so comments with regard to that question. Would anyone like to take that question on? How do you start the induction?
I think Dr. McLean was nodding his head there as you're reviewing that, but yes, it would be restart as you typically would. Unfortunately, we want to give the patients the benefit of the doubt and that they're being honest with us, but I would tend to be careful in that. So start slow and low and get the patients to the least effective dose of buprenorphine if you're using buprenorphine. Methadone, for those that are on methadone, have those specific guidelines of 30 to 40.
So Dr. Patel, how do you differentiate when someone is, if it's determined that someone hasn't been using, or they're certainly not having any withdrawal, which is typically what you expect during an induction, how do you view that, or how do you process that differently?
So that's a great question. And actually, as an aside, we actually have moved over to an OTP for buprenorphine. So we have to deal with some of those issues now where there's just strict COWS criteria for withdrawal management, making sure that the differentiating between withdrawal management versus maintenance versus sustained buprenorphine or MAT. And so for us, what we practically do is we take the patient's prior history. We understand what they've tried in the past, what's worked with them, what's worked for them in the past. We utilize PDMP data. We now that we're part of the OTP, we use central registry to access some of that information. But what we're going to do is we're going to start with the least effective dose. Fortunately for us, which might not be the case for all of the providers that are on this call, we can see them pretty frequently. So we see the patients, especially in those patients that actually we're reviewing a case right now that hasn't used any opioid in the last month or so, but has a significant history. So we're going to bring them back at fairly frequently, potentially 3 days versus a 7 day, see how they're doing, increase them up slowly. So we have the ability to do that. In those instances where we don't, more can be better. We want to give the patients the benefit of the doubt in giving them enough medication where they don't feel like they have to go to their opioid of choice to get rid of the urges and cravings that they're feeling, or potentially withdrawal management symptoms. So for us, we are going to base it on prior history, symptomology, and then giving them that little additional if it's something that we feel, more of a feel than an actual objective data.
Thank you. Other comments, other questions with regard to this case? I think it really does illustrate a common scenario and common enough that it's really valuable to share and also in different perspectives in different contexts of what your patient and community resources are. Anyone else want to talk about a similar case, experience, or different outcome? Hearing none, I will say it sounds like in this case, I'm happy to hear that she has a part-time job and that we're seeing that MAT is making a difference and her access to appropriate care thus far is improving not only her function but quality of life. So that is positive. Let's just go ahead and open it up with regard to any questions or comments with regard to the two discussion items we had today. The case as well as the excellent presentation on benzodiazepines and opioids.
Dr. Schmitz, this is Dr. McLean again. I'm just curious, do we have any LACs on the call right now and what their thoughts would be on that recent case?
If so, please let them speak.
Hi, Dr. McLean. It's Bethany.
Hey.
I'm an LPC. I think, I mean, it's common, but it's a difficult case. And I think, and I actually was going to speak up a little bit ago, but I had somebody in here fixing the light above my head and it was super noisy. So I didn't want to unmute myself. But, you know, going back to, this is a tough case because going back to the thing that Dr. Faust raised, as well as though the providers, at least that I work with, that's a very common thing. So they're willing to try something, and as soon as the patient relapses, they're done. You know, they relapse, they don't trust you anymore, and there's still a lot to learn about addiction and how the behavior of people with an addiction. I mean, it sounds like, I mean, you know, and we all know that relapse it can be and is common amongst that type of population. And I agree too. I mean, she's doing good things. She's, you know, as far as getting a job, she's, you know, all of that stuff too. I think, as far as, and I didn't catch it, I don't know if she's had previous treatment or if she's been in treatment before. But I know that they mentioned she had a history of trauma. She's got some mental health components as well. And I would wonder too, how much of that is being addressed, considered. And then is that, I mean, and I know we need to treat the addiction. And I mean, sometimes if we start to address the trauma, that can cause relapse. But I was just curious as far as that component of it.
Thanks for bringing that up. I think it's an important subject. Would any of the presenters to comment?
Sure. This is Robin. So a little bit about whenever we have the patients who come in, typically what they do is they obviously meet with Kristen, and Kristen kind of confirms the diagnosis, and then she also sets the patient up for an appointment for both Chris and to see a behavioral health provider. And at that point, one of us meets with the patient. We're not LACs, so we don't do a full evaluation with the patient. But what we do is we meet with the patient and we have kind of an interview with them and determine what type of services might be useful for the patient in-house. And then also kind of determine and make recommendations to the PCP on if we think the patient probably needs to be evaluated by an LAC or has some type of service that we can't provide for them. One of the things that we do for the patients before they come in to meet with a behavioral health person is they do a PHQ, they do a GAD, and we also have the patient do the primary care PTSD screener that the patient gets, and we read and go through with the patient when they come in. This particular patient, and I'm sorry that this isn't on the write-up about it, but this particular patient didn't score positive on that, and we still had a conversation because they had a very significant intimate partner violence situation and multiple traumas. So there could have been, there very well could have been some issues related to that. But in speaking with the patient, she didn't have any current symptoms of PTSD. There was no, and in fact, we had a conversation about that. She even said, I very well could have had this. I very well could have had PTSD. I certainly have, you know, this history and things, but the way I kind of feel about it, she couldn't even really deny that some of the addiction treatment, some of the addiction, what was actually related to it. So she actually started using some of these substances after injuries sustained by some of these violence. So she knows that there's this connection, but was not really having any symptoms of PTSD at this time. Wasn't really interested in engaging in any type of therapy related to trauma. And, you know, upon meeting with her, there wasn't anything that really stood out that indicated that we would have needed to go down that road with her. So at that point, we decided that we would be meeting with her for anytime patients come in for to get their prescriptions refilled, they have to meet with a behavioral health person. So we meet with them and we go over, you know, any outstanding concerns with them. And she was definitely going to be somebody that we were going to kind of continue to monitor for that. And so we've definitely been kind of keeping track of all of that when she's been coming in. We didn't see anything that required therapy at that time for it.
This is Lisa Faust. I'm reminded of the topic we discussed last time, which is access to substance abuse treatment. And you know, in this instance, I'd be curious whether your team, in treating this woman, if you had ready access to addiction treatment or assessment to determine what level of addiction treatment support might benefit her. Would that be something that you would pursue? You know, I know that I'm in thinking about this, and in what you talked about in terms of her continuing to, her relapse actually was with methamphetamine. You know, this is a woman who clearly still doesn't have robust refusal skills, I guess. And I think it really highlights the challenges that you face. Is this a gap that you all struggle with?
Yeah, hello, Dr. Faust. I would say that, I mean, I think that it would be great to have an LAC on board, and it's certainly something that we're trying to pursue, just so that we could have the evaluations and the recommendations, and frankly, just to have their opinions be part of our interdisciplinary team meetings that we have, and that they can absolutely, you know, focus more on the addiction treatment of it. We're limited in terms of scope, in terms of what we can do for patients when you're not an LAC. So we certainly would like that. In a perfect world, we would actually like to have an LAC here and a peer support person, because we know that both of those things would actually be the most beneficial for our patients. So if we had them, we certainly could use them, and it is a gap.
And just to be clear, I'm not critical in any way. I understand that you're doing what you got to do. I just wondered if that was part of what the gap for you.
Absolutely.
Yeah, absolutely.
And that helped Dr. Faust too, because that's something that I was wondering about is, you know, was that an option that was discussed to send her to treatment? I think sometimes too, with the trauma part of it, depending on how we look at trauma and how we see trauma, and even how we screen for it sometimes, or what the screening tells us, there's a lot of the situations that we all know that people with addiction that they get into is very risky, and it's very high risk behavior, and they put themselves in situations that cause trauma. So it's not, you know, necessarily that we need to look at the trauma that they had as a child or growing up. It's what is the secondary trauma that they've been involved in as a result of the behavior of their use. Just for example, I met with a 30-some-year-old guy the other day who had a pretty significant, not himself, but his parents were both alcoholics, and mom was a pill user as well, and they would get into this domestic violence stuff all the time. And dad fled because he beat up mom, and he came home to a note that said, I paid the next 3 months of the mortgage, you can stay here, and then you're on your own, when he was 15 years old. So he was homeless from the age of 15 to 21. And what he reported to me when we were talking about what he saw in his household was, he said, I went through and I witnessed a lot worse things when I was homeless and when I was using versus what I saw in my house when I was growing up. So, I mean, even if they're not necessarily testing positive, it's really good. I'm glad you guys are continuing to monitor that, because sometimes people can be triggered without even any awareness of it. And sometimes other people need to point that out to them or say this could be a trigger of your trauma. So it's just something to kind of keep an eye on when we're talking about this population, that the trauma doesn't necessarily, a lot of times patients don't even know that it's potential trauma that they've had. They think that they're maybe, and this kid too, this guy he was 30, he's not really a kid, but identified that he was self-medicating as a 15, 16, 17-year-old. And then, you know, when he sobered up, he said, you know, what was going on in my house was nothing compared to what I witnessed when I was homeless.
So this is Andy. So one of the reasons I asked Bethany, and thanks for speaking up for LAC input, was that issue that, you know, there are the ASAM criteria, placement criteria, what's the most, quote, appropriate level of care, and then there's the reality of being able to do that. And I think we also need to be careful when we talk about, is the person in treatment? It's actually a treatment, it's not the complete treatment. And as you were articulating, there's the therapy for trauma, there's the kind of standard addiction counseling, treatment, et cetera. As I've worked with Valley, I've seen that they work really hard with Northeast Human Service Center and other facilities in Grand Forks and trying to coordinate care. And sometimes, people engage right away. Sometimes they walk into the lobby, they meet with one person and they're out. And then they have this discussion. Well, do we use MAT, as a tool to engage them in further treatment, or do we withhold it and then start at the supposedly best level? And it's those sorts of discussions that happen every day.
And I guess this is Chris. I'll add that I'm really grateful to work in an integrated setting, because I really believe for the most part when we're on our game, our patients. I mean, this patient presented for a Pap smear, and she ended up with MAT. So we ask the questions. We set up an environment. I think our patients know that even if today is not the day they're going to talk about trauma, that if they came in and they felt triggered or they did something, we'd pick up on it, or I think we set up an environment where they feel comfortable talking about it. So she's been to every appointment. She's done anything we've asked her to do in terms of meeting with behavioral health. She's by all means, by any measure that we're doing in terms of our random drug screens and that kind of stuff, she's been super compliant. And we're also providing her primary care. So she's having multiple opportunities to interface with any one of our team, and that's really what I appreciate about that integrated setting.
Yeah.
And I would say,
go ahead, Robin.
We're just very fortunate about that. I mean, we just, we have conversations about how, first of all, just kind of thinking about another patient situation that we had where a patient came in who was a person who is of a marginalized group. And, typically you may have medicine and then you may have mental health, and they're both siloed and completely separate. And you have a patient who comes in and they are, and they're treated well, both by mental health folks, which they may have been independently not treated well by, and medicine, which they may have independently not been treated well by. And in this case, when a patient comes in, they get to have both types of services in an affirmative way, because it's not siloed. So they get to see medicine and they get to see behavioral health, and they come together over them to provide a service. And we realize how fortunate we are about that.
Well, the other thing, Robin, that you're doing is you're training the next generation. Valley has 6 psychology interns that actually are rotating there now, and so it's a great training ground and a place for interprofessional care, and patients certainly experience that.
And this is Bethany again. That's something I was going to comment on, is that even with the lack of resources that you guys have, you've done a phenomenal job. And recognizing, you're screening for depression. You're doing awesome. And I work in a similar setting where I feel very fortunate to be able to see how the integration of behavioral health has grown. And I would say maybe at least every day, at maybe 4 times a week, I will hear from the providers that I don't know how we did this before. And this is something that we should have done a long time ago. And even, I can totally relate to the siloed aspect of it too, because we still have a behavioral health department that is separate from us, but we also have an integrated health therapist in every clinic. And I have just seen the phenomenal growth in the amount of patients that we have touched and gotten to the right level of care because of that.
So let me then interject from a rural perspective, only because I think that the land of silos, rural places, really are tough to silo. And the reason is if, the old joke where it says, oh, let me get you that department, and they transfer the phone, they pick it up and they say, hello, this is the department, and you've transferred it to yourself. I can't tell you how many woman exams, pap smear appointments turned into everything but a pap smear. I remember one case where I was like, okay, it's been 3-4 visits. We probably should do the pap smear this time. But what I call the actual reason for coming is often different, and the needs often are resetting an agenda between the provider and the patient in a primary care setting. And I think that happens in rural environments in part because of the proximity of people and the limited number of staff to get the job done. And frankly, my nurse was probably as therapeutic to many of our patients as anyone was because of the number of touches that happened by phone or in other ways, living in a town of 2,000 people. So I guess my question then becomes, if rural's going to do a really good job of this, and I think we are, if I can call myself still rural, if we're going to do a really good job of this, I do wonder if things like licensed addiction counseling or peer support, those could be done by televideo or by telephone. I mean, right? I mean, and so my question is, I know we're just an educational model, only an educational model here at ECHO. We're not doing case consultation, but is there something to be done or something to be learned here with regard to what is transportable or transmodal to rural environments so that we can say, well, you know, they do a good job over there in the big city, but this is how we do it in rural. We've already got these advantages around being able to wrap services around patients. We just have to do it a little bit of different ways. So any expertise out there, or do we need to search the literature? Where do we go next with regard to getting, right? It's not rocket science to run Zoom, apparently, because I'm not a rocket scientist. So how do we get these resources out to these rural clinicians?
Well, there are some centers that are doing, LAC work, addiction work via telemedicine. I think the trick, Dave, is in doing collaborative care, it really has to be the right fit. I think you have to be careful what you ask for. So the models are certainly out there, but I think all of us are agreeing that there has been a shortage in terms of access to LACs. For those of you who aren't aware, there is, in the upcoming legislative session, there's going to be discussion on the administrative code on addiction counseling.
And I would just add a couple points to that as well, in that one of the great things about Zoom is it's so user-friendly, as you say, Dave, but part of what you're up against is the HIPAA compliance in the 42 CFR. So those are those are surmountable, but they are obviously factors that have to be carefully attended to. I think the opportunity for telehealth is increasing all the time. And so, certainly from a payer perspective, that's broadly open. Anyone can do that with appropriate credentials as long as they have secure transmission now. And that's, I think, increasingly true for all payers. I can only speak for mine, of course, but so the payers, I think, are less and less a barrier for that. The problem with telehealth delivery, however, is that it allows you to extend the workforce to a certain extent, but we really don't have more of that workforce. So currently, ironically, a lot of times, at least within the state, addiction counselors or psychiatrists or mental health therapists would be happy to do telehealth, except they're already busy doing face-to-face. So it is a very helpful extension, but you have to have enough workforce in order to be able to utilize it. And so I think that's part of the initiative within the state to try to help develop more available workforce.
I think you both had my rhetorical challenge really well. That was exactly what I was hoping we'd say. There's also a comment in the box saying, can we train our providers, our current providers, so they're more comfortable with doing things like relapse prevention plans? And I think that's a good suggestion. Those are part of really what we're trying to do here at ECHO. Did I hear another comment?
This is Lisa, and I was just going to comment on, I love the way that the Valley team works as a team, because this is difficult business and they staff these cases, they get consultation. Nobody feels like they have to make the decision alone. They do risk stratification together so that they feel comfortable. And it's really a primary care team. I mean, they're able to do this even without sort of quote unquote addiction expertise, although they clearly have a lot of addiction expertise. But I really think it speaks to the power of the team, and that's part of what's important about integrated care delivery. And then I wanted just to say that I thought it was a lovely thing that you could say, somebody came in and it took 3 times after a pap smear before you could actually get to the root of the problem. And the beautiful thing about using primary care as a place to identify and engage people in substance use disorder treatment is the concept of shame attenuation. There's a lot of shame for people in coming forward just straightforwardly and saying, I need help with addiction. And a lot of times, the same is true for mental health. And so we know that many times people present in primary care for a problem that isn't actually the problem that they present for. And it's easier and it's less embarrassing. And so I think primary care is such a beautiful opportunity place to begin to engage people if the providers can feel more comfortable in talking about substance use disorders, in talking about relapse, to your last point. That it's a really, I think it's a perfect marriage, as I think Bethany was speaking to.
Absolutely, Dr. Faust. I was just going to speak a little bit to that question on how about training more providers. That is a fabulous idea. I am so glad that somebody said that, because since the day I started here at Sanford, I've been trying to do that. The obstacle we run into is getting providers to show up. So I have done some training with the pediatric population, the pediatricians, some with internal medicine and family medicine, but they don't show up to it. And I think part of the reason that they don't show up to it is because it's not something they first of all want to do, because it's hard, as to speak to Dr. Faust's her last comment. It's scary, and they tend to show up when there's a crisis. So when the opiate crisis was all, on the forefront, then that's when they do it. So what we've done, if this is helpful to anybody, what we've done is taken a different approach. We get nurses that show up to the trainings, we get social workers, we get we get different staff that show up. So what we've tried to do, and I know, again, this doesn't necessarily speak to the rural areas because they don't have the resource, but we've tried to take a different approach in, okay, when the provider comes to us to ask us a question, that's when we fill them with information. And we take the teaching approach and the training approach more as a individual one-on-one basis when we kind of have that provider captive. And that has worked. With some of them, obviously, but we've had to become creative in the way that we're approaching the primary care team, because they're busy, and to be honest, they don't always have time to come to a training that we hold at noon or 7 o'clock in the morning, or especially when they have a gazillion things they need to do that day. So we've kind of tried to take it in a different approach of, we need to kind of individually address the concern right in that moment, especially when it's on the forefront of their brain and they're struggling and they're panicking and they don't know what to do. And we can provide them some relief, they're also going to remember it a lot more too.
Hey, Bethany, there's every year in September, I think it's September, there's a pharmacology workshop that we have in North Dakota. PAs and NPs can go and earn CMEs, and I'm wondering if maybe contacting the Board of Nursing and seeing if we can get in and say, hey, we just want to do a quick spiel on addiction and maybe prevention, or I think the big thing is relapse plans. So with the rural areas, if you learn how to do a relapse plan or what exactly you can offer a client, then they're less likely to relapse, right? So maybe something like that would be a good way to get out.
Yeah, absolutely. As most of you probably do too, we have a significant shortage of psychiatry access here. And so the family medicine doctors have have kind of been forced to see some patients that they aren't necessarily comfortable with, including the ones with addiction. And so just recently, because our access is only getting worse, the service chair of family medicine sent out an email to all the providers with links to some educational trainings, CME, continuing education things specifically for psychopharmacology. She sent out a whole like 5 or 6 of them that are coming up, and I hear, in the background, because I'm around them all day, that they're interested and they're going on them, and because they're kind of being forced to at this point, because the lack of psychiatry is so real to them right now.
This is Robin. Just a couple of things in terms of like the rural work. I think there's this thought, this is just my thoughts about it, but there's this kind of idea that if we just get access to these rural areas, through telehealth or something like that, that things will just get better. And I'm just thinking just in terms of counseling and therapeutic services. My only concern about that is there is a difference between doing counseling in a rural community and rural counseling. If you take a therapist that doesn't understand the culture of rural America, their effectiveness for the patient population may not be so great. So I would just say that one of the things that would be really important is that we increase education to clinicians about what rural therapy is about. Because if we don't do that, I don't think we'll be as effective. So that's just my thought in terms of the rural part of it, and getting clinicians out there through telehealth. I think we might miss something if they don't have an idea about what rural America is about. The other thing that I was thinking in terms of providers, one of the things that's a responsibility about behavioral health people being in primary care is, and this is my philosophy, is that this is the medical provider's house, and behavioral health is invited in. And so we kind of make it our responsibility to figure out how we could be useful for provider. And one of the things that we do is we routinely influence their practice as we communicate with medical provider, as we talk to them. And I can tell you that just by reading the notes of our medical providers since I started working here 3 years ago to now, our medical providers' documentation in terms of mental health matters is much better. My CMO talks about avoidance behaviors when she's doing documentation for patients. So I think one thing is that just by proxy, we influence them even if we're not doing a standard training. And then the other thing I think is important is talking to your administrative staff about, like one of the things that we've done for the last 2 years is behavioral health is presented at our staff development days. We've talked about compassion fatigue with staff. We've talked about, we did a de-escalation training where our social worker played a complete jerk at the front desk. So I think there are ways to be able to get the training in without having to close down the shop or figure out a way to, or in some way that's going to get in the way of the flow of things. And that, I just think part of that is just figuring out how can we be creative about it.
I 100% agree.
I really appreciate those comments, and will just reiterate that I think cultural competency is always important. And so when you're looking at rural cultural competency, not all of rural America is like rural North Dakota, and parts of North Dakota are not exactly the same as other parts of rural North Dakota. So I think you're exactly right, and we should be educating our providers and our clinicians with regard to not only cultural competency, but also with regard to the use of the technology and how it can be efficiently, effectively utilized. And my understanding is that we have some educational institutions here in our state which lead along those lines. And so I think that will be changing with regard to the use of telecare, telehealth, and that'll be an important aspect. And it's also good to hear that we're all teachable. So that's the purpose of ECHO as well, is to make sure even a physician such as myself can continue to learn, which I need to do. and really appreciate those comments around, I think, what we have learned, in particular, what I've learned around the value of integrated behavioral health, and then how can we do that in really what is a chasm of the use of increasing technology. So maybe there's some research to be done out there too, or to be resourced. I think we're going to be wrapping up. And so are there any final key points with regard to our presentations? Otherwise, I'll just finish with a couple housekeeping items. Let me say that I want to thank all of our speakers today, both with regard to our didactic and our case presentation. Please let me remind you to make sure that you've signed in on your roster, and also that you complete both your evaluation and your post-test. We're really excited to have these presentations and some of the discussion that comes out of it. And I know Julie and I are here scribbling down notes about where we can see this going to further provide resources for this community, so we can all continue to learn from not only the experts, but from each other as well. Any closing comments from anyone? Seeing none, let me thank you again. We make up the community. Thank you for your participation, and have a good day.